Ձեզ ես այսօր ուզում եմ մի փոքր խոսել սնուցման դասավանդման ուղղված ուսուցման մարտահրավերների մասին, բայց ավելի շատ ուզում եմ խոսել երեխաների մասին, որովհետև կոնֆերանսը հիմնականում հենց նրանց սնուցմանն էլ վերաբերվում է։ Ուզում եմ սկսել մի փոքր իմ ճանապարհից, որ ես անցա սնուցման ասպարեզում։ Շատ լավ հիշում եմ 20 տարի առաջ, երբ երեխաներից մեծացնելուց հետո, արձակուրդից հետո, այսպես ասած, գնացի պոլիկլինիկա, առաջի բանը, որ այնտեղ տեսա, մեզ տվեցին ցուցակներ եւ մենք պետք է սնունդը բաժանեինք երեխաներին։ Ես իհարկե շոկի մեջ էի եւ երբ որ Անահիտի հետ Դեմիրճյան Անահիտի հետ խոսում էինք այդ մասին, եւ ասացի, իհարկե շատ հիասթափեցնող է, որ մենք դրանով պիտի զբաղվենք, միակ բանը, որ մտածում եմ, որ լավ է, որ գոնե երեխաներին սնունդ ենք տալի այսնեղ պայմաններում, Անահիտը ասեց, այդքան էլ լավ չի։ Առաջին պահին չհասկացա, հետո մի քանի օր հետո հասկացա, թե ինչ էր կատարվում։ Շատ մայրեր գալիս էին եւ պահանջում էին պարզապես իրենց բաժինը։ Շատ հեշտ էր իրենց ապացուցել, որ իրենք կաթ չունեն, որտեղ պարզապես կերակրած գալիս էին եւ կոնտրոլ կշռում էին կանում եւ այդ բոլոր մայրերին տալիս էինք այս սնունդը։ Նրանց մի մասը հետո դա օգտագործում էր երեխային կերակրելու համար եւ դադարեցնում էր կրծքով կերակրելը, իսկ մի մասն էլ գուցե կոնֆետներ եւ այլ բաներ էին պատրաստում, նրանցից մեկը նույնիսկ ինձ դրա ռեցեպտներն էր առաջարկում։ Հիմա երբ երեք ես նայեցի ԿԻՄ-ի հետազոտության արդյունքներին նորից, նրա տվյալներով այս ժամանակ կրծքով սնուցումը 4 ամսեկանում 30% էր։ Երբ նայում եմ ստատիստիկ տվյալներին, որ մեզ ներկայացնում է նախարարությունը, 20% է։ Այնուամենայնիվ դա մի 3 անգամ իջել էր։ Եվ մենք իհարկե շատ արագ հասկացանք դա։ Հիշում եմ առաջի անգամ, որ ԿԻՄ-ը ինչպես էր ասում, որ եկել եմ տեսնել ինչ է պատահի հայր մայրիկներին, որ չեն կարող կրծքով կերակրել։ Եվ իհարկե շատ արագ այդ հետազոտությունից հետո մենք ծանոթացանք գրականությանը, հիշում եմ Ֆելիսիթի Սևեչքինգի գիրքը կարդալուց հետո, շատ կուռ այսպես տեսություն էր դա սնուցման վերաբերյալ, որը որ լրիվ հակառակ էր այն ամենին, ինչ որ մենք անցել էինք բժշկական համալսարանում։ Ես շատ արագ այդ տեսության կողմը անցա, որովհետև արդեն 2 երեխաների կերակրելու փորձ ունեի եւ ես կերակրել էի ճիշտ այնպես էմպիրիկ ձևով, ոնց որ խորհուրդ էր տրվում Սևեչքինգի գրքում, եւ մենք դրանից հետո վերապատրաստվեցինք The Start International-ում եւ Կարինե Սարիբեկյանը, Անահիտ Դեմիրճյանը ես վերջնական տեսքի բերեցինք այդ կրծքով սնուցման ազգային ծրագիրը եւ 94 թվականից արդեն սկսեցինք այդ ազգային ծրագիրը կիրառել, ինքն էլ շատ ուր եւ համապարփակ ծրագիր էր, որը եւ կազմված էր մի շարք հրամաններից, որ անմիջապես ներդրվեցին ծննդատներում եւ ուսուցումից, որ ներդրվեց արդեն աշխատող բժիշկների համար, ծննդատներից սկսեցինք, բայց նաեւ մեր բժիշկների համար եւ մայրերի համար հիշում եմ հեռուստատեսությամբ կար այդպես տեսահոլովակ եւ այլ, բոլոր կողմերից կարծես թե միջամտություն կատարվեց եւ շատ արագ դրա արդյունքները երևացին, տեսեք 20%-ը այդ որ ասեցինք 94 թվին ծրագրի սկսելուց հետո շատ արագ, ընդամենը մի քանի տարիների ընթացքում կրկնապատկվեց, եռապատկվեց եւ անգամ քառապատկվեց, բայց իրական փոփոխությունները իհարկե եկան, երբ որ մենք դադարեցրեցինք կաթնախառնուրդների անվճար բաշխումը։ Դուք կարող եք տեսնել 2000 թվից հետո, երբ որ բաշխումը դադարեցվեց, ինչպես էլի մենք առաջընթաց ունեցանք։ Ես ուզում եմ հիմա ավելի շատ անդրադառնամ մեզ համար ավելի բարդ հարցերին, որովհետև կրծքով սնուցման ծրագիրը իր հաջողությամբ, իհարկե շատ բաներ կան, որ պետք է անենք եւս կրծքով սնուցման ծրագրի ասպարեզում, բայց այդ ամենը մեր համար շատ եւ շատ պարզ է։ Ուզում եմ անդրադառնալ ավելի ցավոտ հարցերին, թեր սնուցման հարցերին եւ հավելյալ սնուցման հարցերին, որոնք ավելի քիչ հետազոտված են եւ նաեւ միջազգային ասպարեզում եւ դրա համար մեր համար ավելի բարդ են։ Տեսեք, թերաճության ցուցանիշներն եմ նշել 3 տարիների համար 2000, 2005 եւ 2010 թվականներին եւ տեսեք, չնայած կրծքով սնուցման ցուցանիշները այդ տարիների զգալի էլի աճ են ունեցել, այնուամենայնիվ թերաճության ցուցանիշներն են աճել։ Այսինքն միայն կրծքով սնուցումը խրախուսելու միջոցով հնարավոր չի թերաճության ցուցանիշները իջեցնել, որովհետև նույնիսկ թերաճության ցուցանիշները հնարավոր է, որ ավելի ցածր են մինչև 2 տարեկան երեխաների մոտ շնորհիվ կրծքովսնուցման, բայց դրանք հետո օրինակ 36-47 ամսական հասակում էլ ավելի մեծ աճ են ունենում։ Այսինքն մենք պետք է նաև շատ լուրջ մտածենք նրա մասին, թե ինչպես ենք վարվում այս ծրագրի հետ, այսինքն ինչպես մենք պետք է կիրառենք թերաճությունը նվազեցնելու ծրագրեր, ինչպես պետք է դրանք դասավանդենք։ Տեսեք, կրծքովսնուցումը հեշտ է, որովհետև կրծքովսնուցման մենք ազգային ավանդույթ ունենք։ Ուժեղ համաշխարհային ապացույցներ կան կրծքովսնուցման ասպարեզում, կան գլոբալ խորհուրդներ կրծքովսնուցման ասպարեզում, շատ հստակ են դրանք, կարծես մաթեմատիկական մոդելներ լինեն, եւ լավ մշակված ուսուցողական դասընթացներ եւ մոդուլներ ունենք։ Միջազգային նախաձեռնություններ նույնիսկ կան, մանկանը բարեկամ ծննդատներ նախաձեռնության տեսքով, որը որ հետո մենք ադապտացվեցինք, նույնիսկ մանկանը բարեկամ պոլիկլինիկաներ ստեղծեցինք եւ այդ երկու նախաձեռնություններն էլ շատ լավ ազդեցություն ունեցան։ Նույնիսկ միջազգային օրենսգիր կա, որը որ կրծքովսնուցմանը կպաշտպանի, բայց այս բոլորը այնքան էլ այնպես չի, երբ որ մենք խոսում ենք հավելյալ սնուցման մասին։ Մենք կան իհարկե ազգային մշակութային առանձնահատկություններ, դրա համար է գլոբալ խորհուրդները հավելյալ սնուցման մասին, իհարկե կան հիմնական խորհուրդներ, երբ սկսել, ինչպես սկսել, ինչ հիմնական խմբեր տալ, բայց շատ ավելի մանրամասն խորհուրդներ, որոնք որ ազգային կլինեն արդեն, որովհետև մենք ունենք ազգային առանձնահատկություններ, մշակութային առանձնահատկություններ, մեր սովորույթները սնուցման ասպարեզում, որոնք եթե կան երկարատև սննդային սովորույթներ, դրանք դժվար է փոփոխել, այս բոլորի վերաբերյալ շատ ավելի քիչ տեղեկություններ կան, բացի դրանից նույնիսկ որ ազգային առանձնահատկություններ կան, ամեն տարածաշրջանում անգամ առանձնահատկություններ կան, եւ UNICEF-ը ինձ առաջարկեց, որ Լիանան Կեշի երևի ասեց, այ դու չես ուզում, որ օրականի մասին գրես, թե յուրաքանչյուր օր ինչ դիետա պետք է ընդունեն երեխաները, այ հենց դա կմշակես։ Ես իհարկե դա հաճույքով արեցի, բայց շատ դժվար է հավատացեք, որովհետև երբ որ նույն բանը ներկայացնում ես մի տարածաշրջանում, ռեակցիան մի ձևի է, մյուս տարածաշրջանում ես հիշում եմ, երբ որ Տավուշի մարզում ներկայացրեցի, հետո այն բրոկոլիի համար ամաչեցի, այսինքն շատ սպეციფիկ է, շատ ավելի բան է, եւ այստեղ անհատական կոնսուլտացիաների բանի հարցը շատ ավելի շատ է, եւ սննդի մատչելիության խնդիրներ էլ կան, երբ որ անդրադառնում ենք մեկ եւ թերսնուցմանը, եւ ասենք հավելյալ սնուցմանը։ Այդ բոլոր բաները մենք իհարկե ամբողջացրեցինք, կարևոր է առաջի 1000 օրի շրջանակներում, այստեղ մենք եւ կրծքով սնուցումը եւ մայրերի սնուցումը եւ հետո իհարկե հավելյալ սնուցումը փորձել ենք ավելի մանրամասն տալ, բայց մենք արձագանքների սպասում ենք, այսինքն տեսնենք արդյոք մեր սորաբաժինները կաշխատեն եւ կլինեն, որովհետեւ դրանք զուտ մեր արդեն գիտելիքների վրա են հիմնված եւ միջազգային փորձ կամ միջազգային բաներ այստեղ չկան եւ հնարավոր չեն երևի թե, հա։ Թերաճության մասին խոսելիս ուզում եմ ասեմ, որ թերաճության դերը շատ հաճախ թերագնահատվում է եւ բժիշկները շատ հաճախ երբ որ օրինակ խոսում են թե ինչից մահացավ շատ խիստ թերաճություն ունեցող երեխան, եթե մահացավ թոքաբորբից, պատճառը համարվում է թոքաբորբը։ Այ եթե անդրադառնանք, երբ որ թոքաբորբից մահանում է միավ ձիահ ունեցող անձնավորությունը, մենք ասում ենք, որ ձիահն էր պատճառը, որ տվյալ անձնավորությունը մահացավ։ Չէ՞ որ երկու դեպքում էլ թոքաբորբն է, ուզում եմ ասեմ ամբողջ աշխարհում թերաճության, թերսնուցման դերը իհարկե թերագնահատվում է եւ նաեւ Հայաստանում։ Աճի գնահատումը ոչ լիարժեք է կատարվում, ճիշտ է մենք շատ վաղուցվանից արդեն աճի գրաֆիկները ներդրել ենք եւ աճի սկրինինգները ներդրել ենք առաջնային օղակում, բայց առողջ երեխայի բուժսկողության ծրագրով ես եղել եմ տարբեր շրջաններում եւ կարող եմ ասել, որ աճի գնահատումը ոչ լիարժեք է կատարվում, այդ կետիկները նշելուց հետո միացնում են եւ տեսնում են, որ իջավ աճի գրաֆիկը, բայց ոչ մի հետևանք չի լինում, այսինքն ոչ մի ինտերվենցիա չի լինում դրանից հետո եւ պատճառներից մեկը գուցե նա է, որ չկան աճի խանգարումների վարման արձանագրություններ, հստակ արձանագրություններ, այս շատ տարածաշրջաններում, երբ որ ես ասենք այս աճի գնահատման մասին խոսում եմ, ասում են, հա, լավ, հայտնաբերեցինք, որ երեխան թերաճ ունի կամ ինչ-որ սնուցման խանգարում ունի, ինչ կարող ենք անել, որտեղից սկսենք։ Իհարկե կան այդպիսի, մենք ունենք այդ գիտելիքները, բայց դրանք պետք է սիստեմավորել եւ տալ շատ հստակ ուղեցույցների ձևով։ Եվ ասեմ, որ արտանագրությունների ձևով պետք է տրվեն դրանք։ Մանկաբույժների մեծամասնությունը շատ քիչ ուսուցում է անցնում սնուցման վերաբերյալ բժշկական համալսարանում եւ օրինակ, երբ որ մենք սկսում ենք սնուցման մասին խոսել, ասենք բակալավրերի հետ, այդ 2 ժամում միջև կրծքով սնուցման կեսը հասնում ենք ավարտվում է եւ չենք կարողանում խոսել, ասենք հավելյալ սնուցման առանձնահատկությունների մասին շատ կամ ասենք թեթեր սնուցման մասին, ճիշտ է դրա մասն էլի նյութ ունենք, բայց շատ քիչ է այդ ժամանակը իհարկե բոլոր դասավանդման շատ այլ ասպեկտներին է չի հերիքում, բայց ուզում եմ ասել, որ միշտ երևի թե դա միայն Հայաստանում չի, սնուցման մասին ուսուցումը շատ ավելի քիչ է, քան թե ես կցանկանայի, որ լիներ, ինչու չէ նաև հետ դիպլոմային ուսուցման ասպարեզում ավելի շատ ժամեր հատկացվեց, դրան ավելի լավ կլիներ։ Հիմա իմ գործունեությունը սնուցման բնագավառում 2 ասպեկտներ ունի՝ կլինիկական գործունեություն եւ սնուցման հանրային առողջապահական ասպեկտները։ Կլինիկական գործունեություն ասելով նկատի ունեմ, որ հաճախ մեր կլինիկա եւ ինձ հատկապես դիմում են այն երեխաները, որոնք ունեն սնուցման խանգարումներ։ Իհարկե ավելի շատ դիմում են թեր սնուցում ունեցող երեխաները, թերաճ երեխաները կամ թեր սնուցում ունեցող երեխաները, եւ ճիշտ է մենք արդեն կարծես թե մի փոքր թիմ ենք կազմակերպել, որով կարողանում ենք զբաղվել, որտեղ ունենք եւ էնդոկրինոլոգներ հիվանդանոցում եւ գենետիկ եւ այլն, բայց շատ ավելի կարևորում են, որ ստեղծվեն այսպիսի կենտրոններ, որոնք որ նախ կունենան բավականին տեղեկացվածություն, որովհետև տեղեկացվածության պակասը մենք իհարկե զգում ենք, ինչպես այն ժամանակ մենք ասենք վերապատրաստում անցավ Ամերիկայում եւ 1.5 ամիս հետո մենք լիարժեք մասնագետներ էինք բոլորը սնուցման, կրծքով սնուցման ասպարեզում, այնպես կարծում եմ ինչ-որ մի փորձի պակասի կարիք ունենք մենք, որպեսզի տեսնենք, թե ինչպես կարող ենք ավելի լավ կազմակերպել այս կլինիկական գործունեությունը, որպեսզի մենք իրոք ունենանք տարբեր վայրերում աճի կլինիկաներ, որոնք զբաղվեն աճի եւ սնուցման հարցերով։ Եվ իհարկե սնուցման հանրային առողջապահական ասպեկտներում էլ կարծում եմ, որ պետք է ավելացնենք շեշտադրությունը կրծքով սնուցումից դեպի հավելյալ սնուցում եւ ավելի շատ դեպի սնուցման խանգարումներ։ Հիմա երբ որ օրինակ մենք դասավանդում ենք սնուցման խանգարումները, շատ ավելի քիչ տեղ ենք գուցե հատկացնում, քան թե անհրաժեշտ է, եւ այս սնուցման խանգարումներից հատկապես գիրության պրոֆիլակտիկային կամ բուժմանը կարծում եմ Հայաստանում շատ ավելի քիչ դեր է հատկացվում։ Ճիշտ է, թերսնուցման խնդրը գուցե մեր մոտ գերակշռող է, բայց գիրության խնդիրներ է աճող։ Եվ հատկապես իմ հետաքրքրություններն են սնուցման ոլորտում, որ կուզենայի, որ մենք կարողանայինք համագործակցել, ինչպես ինչ գրականությունից օգտվել, ինչպես դասավանդել, որքան են ձեր մոտ դասավանդման ժամերը, կամ ինչպես եք դուք կլինիկան վարում, այ հետևյալ հարցերի մասին, միկրոնուտրիենտային անբավարարություններ, ցինկ, երկաթ, վիտամին D, վիտամին A եւ այլն, որը որ եւ ուրեմն կլինիկական գործունեության մեջ է մեզ պետք եւ իհարկե ավելի շատ որպես հասարակական առողջապահական ասպեկտ է հետաքրքրում թեր սնուցումը, ավելցուկային քաշը եւ գիրությունը ավելի շատ կլինիկական ասպեկտներով, հիվանդ երեխաների սնուցումը, տարբեր հիվանդություններ ունեցող երեխաների սնուցումը նույնպես շատ կարևոր է մեր համար եւ մալաբսորբցիայի վերաբերյալ կուզենայի ավելի շատ մենք համագործակցենք, որտեղ կարծում եմ, որ տարածաշրջանում բավականին բարձր ցելիակիայի ցուցանիշներ ունենք, լակտազային անբավարարության ցուցանիշներ ունենք, որոնք որ շատ հաճախ չեն ախտորոշվում կամ անգամ ախտորոշվելուց հետո դժվար ենք մենք։ Եվ այս ասպարեզներն է, որ նաև մենք գիտական հետազոտությունների կարիք ունենք։ Ուրեմն կցանկանայի, որ ստեղծեին կլինիկական արձանագրություններ սնուցման խանգարումների, մակրո եւ միկրոնուտրիենտային անբավարարությունների եւ նաեւ ապագա սեմինարներ կցանկանայի, որ կազմակերպվեին սնուցման խորհրդատվության արդյունավետ միջոցների վերաբերյալ, միկրոնուտրիենտային անբավարարությունների ըմբռնման վերաբերյալ, մալաբսորբցիայի վերաբերյալ եւ ինչու՞ չէ շատ հաճախ մենք կարիք ենք զգում խորհրդատվության, եթե ունենում ենք դժվար դեպքեր, երբ որ մի քանի տարբեր բաներ, օրինակ հենց այս սեմինարի նախորդող ընթացքում ինձ դիմեց մի հիվանդ, որը շատ հետաքրքիր եւ մալաբսորբցիայի համախտանիշ ուներ եւ գենետիկ ինչ-որ համախտանիշ ուներ։ Նման դեպքերում մենք կցանկանայինք, եթե հնարավոր լիներ, առցանց խորհրդատվության հնարավորություն եթե ստեղծվեր, որովհետեւ շատ ասպարեզներում հիմա բժշկական համալսարանում դա կա։ Եթե Կոլումբիայի համալսարանը մեզ հնարավորություն տար այդպիսի առցանց խորհրդատվություններ, երբեմն մենք իհարկե շատ ուրախ ու երջանիկ կլինեինք։ Մենք ստեղծել ենք իհարկե UNICEF-ի աջակցությամբ այս վերջերս դեռ չենք վերջացրել այդ աշխատանքը, բայց իմ մեղավորությամբ իհարկե շատ շուտով կավարտենք եւ բժիշկների եւ ուսանողների համար մենք կունենանք էլեկտրոնային դասընթացներ, այսինքն դրանք լեկցիաներ են, որի տակ ուղղակի ձայնով գնում է այն, ինչ որ մենք սովորաբար ասում ենք լեկցիայի ընթացքում։ Ես շատ կարևորում եմ, որ նման բաներ լինեն նաեւ մայրերի համար, որովհետև այս վերջերս ինձ դիմեցին մայրերի մի խումբ, որոնք ունեն Facebook-յան էջ, կրծքով կերակրելու սենյակ էր դա կոչվում։ Իմ կայքը մի քանի օր չէր աշխատում եւ նրանք ինձ ուղղակի դիմեցին, ասեցին, ինչ է պատահել ձեր կայքին, մենք ձեր կայքից օգտվում ենք, հիմա չենք կարողանում օգտվել, բացի դրանից ասեցին, որ ավելի շատ տեղեկատվության կարիք ունեն եւ կարիք ունեն, որ իրենց պարզապես մասնագիտական օգնություն ցույց տան, որովհետեւ դրանք շատ ինտուզիաստ մայրեր են։ Մի շաբաթվա ընթացքում 400-ից այդ մայրերի թիվը 600-ից ավել է անցավ, մի շաբաթվա ընթացքում եւ Հայաստանից մայրեր կան, եւ արտասահմանից հայ մայրեր կան, որոնք իրենք շատ լավ օգտագործում են գրականությունը, բայց ելի խորհրդատվության եւ գրականության կարիք ունեն։ Կարծում եմ, այս հարցերին էլ կարող ենք մենք ավելի շատ անդրադառնանք, ավելի շատ աջակցենք երևի մայրերին, որովհետեւ միշտ մեր սնուցման բոլոր ծրագրերում ազգաբնակչության հետ աշխատանքի կոմպոնենտը կարծես թե ավելի վատ է կատարվել, քան թե մնացածը։ Այսքանով ուզում եմ ավարտել իմ խոսքը եւ շնորհակալություն հայտնել։
Արտականություններին։ Եթե հարցերը, լավ, հետո հարցերը աշխատանքային թույլ տվեք ես ձեզ օգնեմ։ Լավ, երկու հնչեցված երկու երևույթի վերաբերյալ ուզում եմ մի փոքր մեկնաբանություն անել։ Լարիսա Ռաֆայելնան խոսեց քաշի կենտրոնի մասին, դուք ասեցիք խորհրդատվական կլինիկաների մասին, ես ուզում եմ այդ երկու գաղափարը այսպես միացնել։ Մեզ մոտ աստիճանաբար, քանի որ մենք համագործակցում ենք արևմտյան համալսարանների, Ամերիկայի Միացյալ Նահանգների համալսարանների հետ, փոխվում է հասկացությունը կլինիկայի վերաբերյալ։ Ինչ է կլինիկան մեր ավանդական պատկերացմամբ, դա բաժանմունք է հիվանդանոցում, որտեղ գնում է ուսումնական պրոցեսը։ Եթե մենք խոսում ենք outpatient կլինիկայի մասին, ինչը շատ ավելի մոտ է իրենց հասկացությանը, նա in hospital, սա outpatient։ Այստեղ մենք հիմա ուղղություն ենք այսպես բռնել համալսարանում բացելու պրոբլեմային կլինիկաներ, պրոբլեմային, օրինակ հազի կլինիկա, ցավի կլինիկա, այդպես հիմնված պրոբլեմի վրա, ինչը լուրջ անդրադարձ կունենա կրթական պրոցեսի վրա։ Ոչ թե նոզոլոգիական, դիսցիպլինար մոտեցում, այս հիվանդությունը, էտիոլոգիա, պաթոգենեզ եւ այլն, այլ պրոբլեմի ճանաչումը, ճիշտ բանը, գնահատումը եւ լուծման ձևերը։ Դրա համար, քանի որ քաշը հանդիսանում է սնուցման հետ կապված խնդիրների ինչ-որ շատ լուրջ կլինիկական դրսևորում, թե ավելորդ, թե պակաս, կարելի է անվանել weight clinic եւ այդպես գնա առաջ։ Ես կարծում եմ դա մեր կողմից կողջունվի եւ անպայման կանգնի այդ կլինիկան այն շարքում, որ ասեցի, հազի կլինիկա, ցավի կլինիկա եւ քաշի կլինիկա։ Պրոբլեմը կլուսաբանվի կրթական ծրագրերում։ With great pleasure I am inviting Sharon Akabas from Columbia University to hear a very interesting information about the challenges to integrating nutrition into health professional educations in the United States. The floor is yours, please.
Okay, but first, you've been been sitting for a long time, so we want you to stand up and play a game. You know the game? Rock, paper, scissors. Stand up. Nobody does it 3 times. Stand up. Yeah. Ready, Russ? Who wants to do it? Stand. I can wait. Okay, ready? Rock, paper, okay. Okay, we're almost at the break, almost at the coffee break, so I'm going to try to reduce my slides to about, at most, 15 minutes. From the presentation this morning and this presentation that I'm going to give you, I'm going to skip some of the slides. You'll have all the slides available to you. So I work at the Institute of Human Nutrition. And in 1985, many years ago, Dr. Myron Winnett, prior to 1985, had begun working on integrating nutrition into the medical school curriculum. And he worked nationally in the United States, and he led an initiative at the Institute of Medicine to focus on the importance of integrating nutrition into medical school curriculum. And as a result of that meeting, there was some people thought it was a mandate. It wasn't actually a mandate, but there was a supposed requirement to have 25 hours of nutrition in 4 years of medical school, and that was in 1985. And now in 2014, very few medical schools in the United States meet that standard. In fact, it's gotten much worse over the years that we've been working on this. So in the last few years, there's been an initiative to reinvigorate the whole process, but not to limit it to training of physicians, to expand the initiative to include all health professionals. And I understand that that may be a different challenge for you here in Armenia. I would just ask you to think about the advantages of not only training physicians and also training anyone who interacts with patients, with communities, because the value of having common messages is considerable. So if someone sees a physician, sees a nurse, sees a community health worker, sees a dentist, sees a psychologist, sees a physical therapist, all of those health professionals can convey the importance of what we eat, how much we move, how much we sleep. And the more we message that in a consistent and common way, the more we can help people achieve those behaviors. In shortening my comments, the other thing I'm going to skip to is the program that we've developed at Columbia University, and Dr. Hakimian is a key part of that program. Where at Columbia, the focus is not only on biochemistry, and I love biochemistry, that's my primary training. It's on the recognition that knowledge and scientific knowledge are rarely sufficient to help change behavior. And there is now an entire science around the complexity of behavior change, and that's the focus of our health professionals course. We teach a lot of the basic science, we teach nutrition through the lifespan, we teach clinical nutrition, and we spend a quarter of the time talking about trying to understand why we don't and our patients don't do the things that seem to be in our best interest. And so I'd like to introduce you to the ways that we're approaching this nationally and then focus a little bit on what we're doing at Columbia. So I mentioned that it's an uphill battle, that we have the same challenge you do. There's more information that has to be conveyed in training and there's less time to do it. The talk that I am speeding up here, I gave with a Dr. Doug Seidner at Experimental Biology, and the talk was divided into what we need to do and how we might do it. And the things I want to focus you on is that in the United States, there's a move towards competency-based training away from objectives learning. And I'll show you some slides related to that. I'll give you a very quick overview of the competency framework, and then when we look at how we might do it, we'll look at existing nutrition and physical activity competencies that exist, and provide examples of successful competency-based interprofessional education and make recommendations for next steps. So this is a complex slide. The only reason I'm showing you is this first to these lines, recognizing that in the United States, the whole approach to training health professionals is changing from a structure-based or a content knowledge acquisition to a competency-based approach where we're looking at outcomes and trying to understand knowledge application. What can the health professional do? And in doing that, it's a shift also in the hierarchy where we look at how education is performed. So rather than it being teacher-based and me standing here and telling you what you must learn, educators are looking at the students and trying to understand much more how our students learn and how to help them learn key ideas. So the shift is from the teacher to the learner, and that's relevant to our changes in approach to clinical practice also, and I'll come back to that later. And this path of learning, the hierarchy is, frankly, I'd rather it be, you must do what I tell you to do as a teacher, but that's no longer the approach that we take to learning, and it's much less hierarchical. It's teacher and student in a collaborative learning process with the teacher as the expert. Again, I'll come back to why that's important later. The ways in which they're looking at this in terms of the pyramid of clinical competence is that knowledge is still important. It's not as though knowledge has dropped out of this. It's important, it's the base of the pyramid, but we're going from knowing to knowing how, to showing and to doing, and to becoming an independent practitioner. And the domains in the medical curriculum nationally in the United States, there were originally 6 domains and 2 domains were added, but these 8 domains are fundamental to every medical school curriculum in the United States. And they include patient care, knowledge for practice, practice-based learning and improvement, interpersonal and communications skills, professionalism, systems-based practice. Interprofessional collaboration is one of the domains that was added, and personal and professional development were also added. So in the interest of time, I'm going to skip through many of the remaining slides, but we think this is a reasonable place to have every health profession look and see if these domains are relevant to your training and which ones you might integrate. I'm going to skip through these outcomes project and go to the idea that we don't expect this to happen in 1 year. In the case of medical training, we recognize that there's the novice, there's the advanced beginner, there's the beginning of competence, there's proficiency, and the expert. And so all of this training, in this case, is in the residency phase, the postgraduate phase. So as you were saying that you recognize that some of the initiatives have to be at the undergraduate level, some at the postgraduate level, and some at the attending level. The same is so in the United States. The important thing to recognize is in this initiative, everything is going to be evaluated, so there are specific templates that are part of a milestone project that give you an idea of whether or not you've reached level 1, 2, 3, or 4 in each of the goals that's set for a knowledge-based and then ultimately a skill-based competence. So medical schools right now are all very, very busy figuring out how they're going to achieve these different competencies throughout their curriculum, how they're going to measure and track the students. And the competencies that are identified as relevant to nutrition for select advanced, in this case this is advanced practice nursing. So here we begin to shift from what we want physicians to understand to recognizing that having nurses and everyone on the team giving common messages, that in nursing practice they're looking at a similar approach. I just want to draw your attention to the reference on this slide. When you have the slide, this is a reference from a recent conference and series of papers that we participated in that track the history of nutrition education for health professionals and where we make recommendations for how you might do it. So it's a very useful reference for you. I want to now turn to, this is the what we want to do. I want to turn now to the how we might do it. And we're going to review the existing materials, and I'm going to give you some examples. The idea that I want to convey in this next section is that this job is a difficult one, and we think it will be most successful the more people with whom we interact. But we can't wait for those relationships to be formed. We can't wait for those perfect systems to be formed. So rather than starting at the base of the pyramid and what I'm going to show you, I'm going to start at you, which is the individual unit. You already must have an interest in this, and you as individuals can be very important role models as practitioners and educators, showing anyone with whom you work and whom you train the importance of nutrition, physical activity, and all of the other factors we've talked about. So although it's a daunting task, you all have the capacity to make a difference in this area. The difference you make can be strengthened the more connections you make. So if you have a curriculum coordinator, or you have the beginning of a process, an education and evaluation team, find out who they are in your practice or in your educational institution, and tell them you want to work with them, and you will have made their day and made their week, because we all need you to come and identify yourselves and work with us. Wherever you can, look for other people within your institution who are working on interdepartmental teams, and this can be very, very broad in the way that you think, because preventive health, you could work with engineers, you could work with people in community planning on how to figure out how to make a building or a community one that will be walkable and safe. So think very broadly in this area. And then continue to broaden your connections with interprofessional teams and try to identify with your team what are some common core competencies that you can agree on and that you can start now to message. And there are many things based on what you already know, perhaps what you've learned through this conference, that you can agree would be useful in practice, identify them, share them, figure out how to best message them, and figure out whether or not they're appropriate to the community with whom you're working. That's one of the most important things to do. In the United States, one of the things we're trying to do is to get this to the level of accreditation, because in general, when we do education initiatives, it doesn't matter if we do it unless we test or it has some value for the student. So getting it to the board level, getting it to the accreditation level is another level to try. At Columbia, when we were charged with these challenges to integrate nutrition into the medical school curriculum, the first thing we did, we didn't know Kim at the time, but we used a principle that Kim has taught us all, which is look at what you already have. And what we did here, we looked at the existing curriculum, and any place that you see green, it means that nutrition was actually being taught, just not labeled as nutrition. So wherever you're in your practice or in your materials, start to see where you can either label it as nutrition or label it as physical activity, label it as something that now your patient, your family, or the people with whom you're working recognize that you really are talking about nutrition and you know something about it. The other thing here is some of the competencies that we identified at that time, and we think those are some very useful ones also as a starting point if you need help in figuring out where to start. So at the Institute, in part because we weren't really that successful integrating nutrition into the medical school curriculum. We've developed two programs, one which is a traditional master's where the students come before they go to medical school. They have a full year of very intense learning in basic science, nutrition, and they do a thesis project. And I think the thesis project for, or some kind of a research project for medical students or trainees is a wonderful opportunity for trying to figure out how to integrate nutrition into their training. The other program we have, which I mentioned Kim's very active in, is the Health Professionals Program. We've already enrolled in 2 years in the program 40 health professionals. They come from a range of practice, and in the next slides I'll explain a little bit more about how we've integrated behavior change heavily into the curriculum. And we are in the process, of course, with Kim. Anytime you have Kim, you want to do qualitative and quantitative evaluations, and we're in the process of doing it. And here we see the slide again that I showed you at the very beginning, where here we're looking at the driving force for curriculum change. Here again, we want knowledge application in terms of our learners. And in practice, we're recognizing that the driving force for changing practice is the practitioner has become eager to switch their own abilities to competency-based, and the patient has become the center of learning. And there's become less of a hierarchy in the United States between the practitioner and the patient. It's seen more as a collaborative process, with the practitioner having knowledge and expertise, and the patient being an expert in their own lives, in their own bodies. I'm going to skip over this, but in the United States, the reason this is here at all is there's now a movement towards prevention. It's included in the Healthcare Act, and there are ways in which reimbursement now favors all of the things we've talked about in this room. So for anyone involved in health policy, this is one of the things you could perhaps model, is looking at the healthcare system itself, and also looking at models of chronic care and how some of the things that I've talked about can be integrated. So in terms of the interprofessional education conclusions, what we saw as the next steps were to select and the published competencies that are relevant to nutrition. I'll show you that again. To assist in the development of nutrition-related milestones for healthcare professionals, you will have to make some of those yourselves. You can look at what already exists and then adapt them to where you can reasonably begin. Then we want to recommend how the milestones and evaluation can be integrated into the accreditation process, and determine the cost impact of improved patient care, because we believe these approaches will have tremendous cost-saving effects. So I just want to now skip quickly to explain a little bit about, I have 2 minutes, I'll try to use 1.5, to explain the approach that we're taking to the complexity of behavior change. And here we're using a few different approaches. Dr. Dinkiewicz mentioned motivational interviewing. We have everyone trained extensively in motivational interviewing. We also bring in cognitive behavioral psychologists to teach about cognitive behavioral psychology and the changes in brain activity associated with helping someone change their thinking and acting pattern. We also bring in someone who's involved in psychodynamic understanding of behavior. Again, why don't we do what seems to be in our best interest? We have someone come in and train us on harm reduction. Smoking is an excellent model for harm reduction, where we're not having necessarily the expectation that there'll be complete cessation of the habit, but doing better is doing good. So anyone with whom you work who smokes one less cigarette every day, that's better than the day before. Anyone who has substance abuse issues, if they're using less, we're moving them towards a more healthful pattern. That's a concept of harm reduction. And the last thing we do is we bring in someone whose expertise is health literacy, because many times the messages that we give are not at the level of people with whom we work, and we're talking here, they're listening here, or we're giving too much information like I'm probably giving you right now. And so the focus becomes on how to message and change the way we approach teaching, again, so it's much more of a collaborative process. So these are some suggested readings, and thank you for your time.
Քանի որ մենք շատ հետ ենք մնացել մեր ժամանակացույցից, ես առաջարկ ունեմ, որ հարցերը տակ սուրճի ընդմիջման ժամանակ 10 րոպե սուրճի ընդմիջում կանենք եւ խնդրում եմ ժամանակին հետ գանք, որովհետեւ մենք 1:45 պետք է վերջացնենք։
Well, we're coming to the last part of this conference, and we're going to be hearing some examples, it's not going to be the whole field, relating to clinical issues in nutrition. And our first talk is going to be on calcium, vitamin D, and bone health. And welcome back, Dr. Boziki.
Well, thank you, Richard. We're going to talk about calcium, vitamin D, and how it relates to nutrition and bone health. I am an endocrinologist, and I like hormones. I like to discuss the regulation of nutrients in a regulatory way. So I'm going to give you a little bit of an introduction about the way I think about calcium and vitamin D metabolism. And let's begin by just introducing us to the three major organ systems that regulate our calcium and our vitamin D. And they are the skeleton, the gastrointestinal tract, and the kidney. Now, this is a very simple cartoon, but very quickly it becomes very complicated. It becomes complicated because there is a dynamic interface at the gastrointestinal tract. The kidney, you'll notice the kidney filters 10,000 milligrams of calcium every day. And the bone that turns over about 500 milligrams of calcium. This is a very dynamic, active system to keep our calcium in regulation. Now here's the first principle. Hormonal mechanisms keep the blood calcium within normal limits at all times under general homeostatic conditions, even if calcium balance is negative. So let me give you an example. This is the calcium concentration, the lower normal, upper normal, and this is your calcium concentration, day after day after day. When you eat, or when you don't eat, you really cannot tell that the serum calcium is a little higher or a little lower, because the body wants your calcium to be very, very constant. Now the way this happens is through two hormones. One, parathyroid hormone, and the other we still call a vitamin, but it's a hormone, vitamin D. Let me give you an example of a situation where the calcium goes up in the blood by just a little bit. That happens if you take a calcium pill. But you can't tell, you cannot measure a 1 to 2% increase in the blood calcium when you take a calcium pill. But the body immediately knows that the calcium has gone up by a little bit, and that hormone, parathyroid hormone, registers that small increase by a large reduction in parathyroid hormone. What parathyroid hormone is doing is trying to keep the calcium normal. If it's low, it will pull calcium from the skeleton. It will save calcium in the gastrointestinal, in the kidney. And if it's low, then the opposite happens. Now let me cover vitamin D very briefly. When we say vitamin D, we have to be careful about what we are talking about. Vitamin D is metabolized to 25-hydroxyvitamin D. That happens in the liver. 25-hydroxyvitamin D is dihydroxylated, that is a 1-hydroxylation, in the kidney to form the active hormone, 1,25-dihydroxyvitamin D. When we speak about normal vitamin D levels, and we're going to talk about that, we're actually speaking about this product, 25-hydroxyvitamin D, because that is the storage form of the vitamin. We don't measure vitamin D, and we rarely measure 1,25-dihydroxyvitamin D. So when we speak about what is normal, we're actually speaking about 25-hydroxyvitamin D. What vitamin D does is to regulate our blood calcium, again, to try to keep it normal by mobilizing calcium from the skeleton, and different from parathyroid hormone, facilitating the absorption of calcium from the gastrointestinal tract. So here's principle number 2. Osteoporosis, and we have not discussed osteoporosis very much at this meeting, but I would like to invite you all to a meeting we're going to have on October 15th this year, and this will be our 8th annual symposium on osteoporosis that's going to be held at the Marriott Hotel, and we would like to invite all of you to that. But let me just comment about osteoporosis being a state of skeletal calcium deficiency, but it is not associated with any abnormalities in the blood calcium. The typical patient with osteoporosis has one of these three: normal calcium, high calcium, or low calcium. And the answer is normal. So typically, the calcium in the blood in a patient with osteoporosis is normal. Now, obviously, there are situations when the calcium is high, the calcium is low, but those are specific diseases, not what we call postmenopausal osteoporosis. This is menopausal osteoporosis. You can see that there is skeletal loss and there's microarchitectural deterioration, a disorder of skeletal calcium deficiency and microstructural defects. As I said before, a skeletal calcium deficiency state, not a state of abnormal serum calcium concentration. Osteoporosis is associated with bone loss and microarchitectural deterioration. Now let's move this back into the nutrition world and say that childhood nutrition is a key element in this disease that we typically see in adulthood. Why is this so important in terms of childhood nutrition? It's because children gain calcium, they accrue calcium as they grow, and they reach their peak of skeletal calcium somewhere in the ages of 20 and 30s, and then they maintain it for another 10 years, and thereafter bone calcium drops. But the concept is that peak bone mass is a major determinant of bone density and strength throughout life. Let me give you an example. This is example A. This is a child who has grown and gained a lot of calcium in the skeleton and reached a very nice level. But let's take patient B, this is child B, who hasn't done as well. For whatever reason, she has not achieved as much peak calcium in her skeleton as is the case for patient A or child A. Well, if child B doesn't do that well, as she grows up and becomes an adult and starts to lose calcium, she will reach this threshold, which we call osteoporosis, faster than the person A who started with more calcium to begin with. What we would like to do in terms of optimal nutrition is to make this child B like child A. Now let's take another example. This is child C. Child C has failed to acquire bone mass even in the low normal range. She's very much below, and it may have a number of things to account for it. Small size, heredity, maybe she had late or missed puberty. And what about stunting? This is something that no one has even begun to think about. But clearly stunting is affecting all aspects, I think. And this is something that we ought to look at. But I would say to you that this big problem of stunting in this country is also not permitting these young children to reach where they want to be. Their skeletal mass is also going to be compromised. And if it's compromised to this degree, then when they become adults, they're already going to have reduced bone density, and their osteoporosis is going to be manifested much earlier. Again, here would be the goal, to get this child up to B, or maybe we could get this child up to the optimal peak bone mass. So determinants of peak bone mass, multifactorial. Certainly genes are important, body size and weight. Exercise in childhood is very important. We keep talking about smoking, which is bad for everything, and teenagers who smoke, they may not reach their peak bone mass. Sex hormones are important. But let's not forget nutrition. Calcium, vitamin D, and adequate protein are key elements to achieving peak bone mass. Principle number 3. The strongest predictor of bone density in the later years of life is low bone density in the younger years of life. It happens to be true. Now, what about calcium intake in children in Armenia? Actually, I do not know. There was a United Nations survey in 2005. This seems hard to believe, but this is what it said, that the average intake of dairy in 2005 was only 2.5 servings per week, and only 8% of the daily caloric intake was based on dairy, and well under nutritional recommendations. If that's true, and I don't know that that's true, we have a lot of work to do to try to get calcium intake up to the latest recommendations of the Institute of Medicine, and this is actually only 2 or 3 years old, and these are the recommendations for infants, toddlers, and children: 700 milligrams, 1,000 milligrams, 1,300 milligrams, and then the later recommendations for adults, 19 to 71, are 1,000, 1,000. For women between 50 and 70, 1,200 milligrams, and for all people, men and women, over the age of 71, the recommendation is 1,200. And you'll notice now that the Institute of Medicine has recommended maximal amounts of calcium, because we're recognizing that there is a limit to this, and you can get, there can be negative consequences if you are taking too much calcium. So, preferably calcium intake should come from natural sources, dairy, the major source. Calcium supplementation is used only to make up the difference between the amount of calcium in foods and what you need. And if you're going to supplement calcium, we use 500 to 600 milligrams, no more than that at any one time. And we advise calcium supplements to be taken with a protein-based meal where absorption will be more efficient. The best sources of calcium, of course, are dairy products, certain green vegetables, certain nuts like almonds. And as I mentioned, the calcium supplements typically are calcium carbonate, or calcium citrate, and I've made my comments. Now, how much calcium do we need in this country? Well, we don't know. But let me say that calcium is what we call a threshold nutrient. That means that calcium balance improves up to a certain point, and then any more calcium, you get no more benefits. Now, it turns out that in Caucasian women in New York, calcium balance is reaching its maximum at about 1,200 milligrams. It turns out that Chinese women in New York need much less because their absorption efficiency is much greater. So Chinese women in New York need about 600 or 700 milligrams. No one has done any work on what the threshold value is in terms of Armenian women in Armenia. And one might guess it's probably about 1,000 or 1,200, but this is really not known. So in terms of calcium, what we are recommending is drink your low or no fat milk, eat your mazun, cheese, and you use calcium supplements only to supplement. Okay, let me move on to vitamin D. If we don't have enough vitamin D in our system, it doesn't matter how much calcium we get in, we will not absorb it efficiently. So a calcium sufficient diet is not an adequate diet unless we have sufficient vitamin D. As I mentioned before, this is the scheme. This is what we measured, 25-hydroxyvitamin D. Elena Agajnova spoke with me about how expensive the vitamin D test in this country is. It's about $25 US per sample. Is that about right? 20,000 drams. 10,000 drams. So 10,000 drams for one test. Very expensive. And because of that, we don't have that much information on vitamin D adequacy, but we know a lot about vitamin D throughout the world. And the point is that vitamin D deficiency is very common. Now you may ask, why is it very common? Because we have the sun. And the sun should provide the energy to convert 7-dehydrocholesterol in the skin. The problem is that vitamin D through the sun is seasonal. To a certain extent, it's latitude dependent. We are concerned about the sun because of skin cancer and the rest, so we use sunblock. There are some parts of the world where people are completely covered. There's also environmental issues, like in Beijing, China. I think the sun never shines in Beijing, China. And the dermatologists tell us to avoid the sun. So really, the sun is no longer a source of vitamin D, in effect, throughout the world. So if we do not get our vitamin D from sunlight, where else can we get our vitamin D? Well, we can get it from food. Unfortunately, there isn't very much vitamin D in food. And here are some of the foods that are said to be rich in vitamin D, and they're not very much. Cod liver oil, 1 teaspoon is 400 units, and the typical diet, American diet, is very deficient at all ages and in both sexes with regard to vitamin D adequacy. So without sunlight as a source of vitamin D, and without food as a source of vitamin D, most of us are probably vitamin D deficient. And here are the data. Here's from the United States. Dr. Neil Bakley has shown that in where he lives in northern U.S., almost 60% of the patients he sampled had levels of 25-hydroxyvitamin D that were less than 30 nanograms per ml. And Dr. Michael Hollick has divided the United States into 3 tertiles of latitude and has shown that, it really doesn't matter whether you're in the northern part of the United States, the middle, or the lower. Vitamin D deficiency is anywhere from 25 to 42%. And this is from the world literature from Professor Lips in Scandinavia, where he sampled 2,500 postmenopausal women, 18 countries in the latitude including Armenia, and 64% had serum 25-hydroxy levels that were less than 30 nanograms per ml. Now, I mentioned 30 nanograms per ml. The question is, how does one determine what is normal and what is abnormal? What value of 25-hydroxy vitamin D should we aim for? Should we look for 20 nanograms per ml? Or should we look for 30 nanograms per ml? Now, you would like to have some physiological data to support whatever you think. And here's some physiological data with regard to parathyroid hormone. This study showed that when the 25-hydroxy vitamin D falls below 30 nanograms per ml, the parathyroid hormone level goes up in a very sensitive way. That relationship between vitamin D and parathyroid hormone suggests that we want to have a level that's at least 30 nanograms per ml. Another study from Dr. Robert Heaney showed that in patients who have normal 25-hydroxy levels in yellow, they have better calcium absorption and they have reduced parathyroid hormone. So most of us believe, based on that and other data, that the minimum normal level for 25-hydroxy vitamin D should be around 30 to 32 nanograms per ml or 80 nanomoles per liter. However, the Institute of Medicine, which we all respect very highly, 3 years ago said, no, shouldn't be 30 because there's no convincing evidence of what I just showed you, that parathyroid hormone levels consistently rise when the 25-hydroxy level is less than 30. There's no convincing evidence, although I showed you some, that optimal calcium balance requires a 25-hydroxy level greater than 30. There is no convincing evidence that the skeleton needs levels greater than 30. There is no convincing evidence that all of the putative non-skeletal actions of vitamin D need levels greater than 30. They said that we should aim for 20, because if you get to levels less than 20, then they're clearly experts in the world, as well as most of the professional societies in the world, have not changed their view. And we continue to recommend that the normal range for 25-hydroxy vitamin D be between 30 and 80 nanograms per ml. The lower limits would be 30, and the upper limits would be between 50 and 80. There were some slides showing that there might be some negative consequences to levels of 25-hydroxy vitamin D that are greater than 50. I think those data are really inconclusive, and I think, on the other hand, there is a lot of upside safety to level up to 100 nanograms per ml. Vitamin D measurements are not practical because they're expensive in this country, and you're not going to measure vitamin D levels routinely unless you have a specific problem. So how do we ensure that the Armenian population has normal vitamin D levels? The recommended intake is, I said, 600 units under 70 years of age or 800 units over 70 years of age. And the maximal intake is 4,000 units. Now, one suggestion would be, is when you see your patient for the first time, maybe you should recommend a fairly generous amount of vitamin D, 2,000 units per day, for 2 months. And then move to the levels I mentioned before, assuming that you will have gotten the level up to where you want it to be, and then to reduce the level of vitamin D to the new Institute of Medicine guidelines. A couple of last comments about vitamin D. One with regard to fracture risk. Some studies, but not all, have found a reduction in fractures with supplementation, not consistently seen. And it's not clear. The conflicting results may relate to differences in baseline vitamin D status, the range of doses used, and compliance. So the fourth principle is that calcium and vitamin D sufficiency, along with an appropriate exercise regimen, are always recommended to everyone, particularly those who have osteoporosis. Treatment for osteoporosis alone with calcium, vitamin D, and exercise, although recommended, are rarely sufficient. I have patients tell me, Dr. B, I don't need any of these fancy drugs. All I need is calcium, vitamin D, and exercise. Not true. Pharmacological agents are typically needed in those situations. And let me finally make a comment about the so-called non-skeletal actions of vitamin D. This was a very popular idea a few years ago. It suggested that if a person was vitamin D deficient, there would be issues with blood pressure, heart attack risk, peripheral vascular disease, sudden death, cardiovascular mortality, and overall mortality. There was also some evidence to suggest that people who were vitamin D sufficient were going to be protected from falls, they had better muscle strength, they would be protected from cancer. There was an immunological competence that was believed to relate to some of T-cell mediated actions of vitamin D, improved cardiovascular health, improved vision, and improved thinking. This seems fantastic. Everybody should have lots and lots of vitamin D. Not clear whether any of these issues are really the case, although we do think that vitamin D does protect against falls, it does improve muscle strength, and there probably is some evidence in terms of improving immunological competence. So let me leave you with this whirlwind trip through calcium and vitamin D and suggest that calcium homeostasis is exquisitely controlled. The body protects itself from abnormal blood calcium levels becoming abnormal in most situations. And the key to this are the elements, parathyroid hormone, and vitamin D. There is an epidemic of vitamin D deficiency throughout the world, and I'm sure including Armenia. But we have to remember that good calcium and vitamin D nutrition are always keys to good skeletal health. Thank you very much.
Well, thank you very much, Dr. Bolzicki. That was really terrific. And we have another thing that we have to make better in Armenia. And our next talk in clinical issues of nutrition will be given by Andrew Thorne Lyman, Nutrition in Special Clinical Populations, the Case of TB Patients.
Thank you. I might need some help finding it. While we find it, though, I can say at the Harvard School of Public Health, where I came from, vitamin D is the only supplement that every single member of the faculty takes. At Harvard. The best school in the world. Except for Columbia, maybe. It's outside. Okay, thank you. Just to give all of you a little bit of background about how I came to this issue, up until about 6 years ago, I was working at the World Food Program, UN World Food Program, in the headquarters, and I worked there for about 8 years, specifically on issues related to nutrition and food and HIV, and this was just as this became sort of a popular issue in about the year 2000. In 2003, the World Health Organization for the first time reviewed the evidence related to nutrition and HIV, and for the first time established what the needs are, the potential needs are of people with HIV. So I was originally going to just do it on nutrition and tuberculosis, but I was asked, I know that there's a lot of people in the room who are also interested in HIV, so I added a little bit there as well. So today I'm just going to give a quick overview of the epidemics, these dual epidemics. going to talk about how nutritional status affects and influences TB transmission as well as treatment outcomes. I'm going to go over some recent guidelines that the World Health Organization issued related to nutritional support during TB treatment. And I'm going to talk about the role of food in programs related to TB and HIV. So tuberculosis has been with us for a very long time. It's documented, there are Egyptian texts documenting this. This is a mummy from the year 2000 BC that they found, I think in Peru, with evidence of tuberculosis. Today it's probably the most widespread infection, I would say, or chronic infection. It infects 2 billion people. Now, not all of those people have infectious, active disease, but over the course of their lifetime, about 10% of people who have the latent form of tuberculosis will go on to develop it. In 2012, it's been coming down. In 2012, there were 8.6 million new cases, but it remains the number 2 infectious disease killer. You can see there some of the estimates related to infant deaths and adult deaths. Certainly contributes to a lot of the avoidable deaths worldwide. And the greatest shame of it is that it's highly treatable. We have drugs to treat it in most cases. It does require treatment for quite a significant period of time, for months, but it is treatable, and we've had treatment for a very long time, and yet it remains the number 2 infectious disease killer in the world. Now, at the same time as the TB epidemic, we also have this co-epidemic of HIV. And in total, there's about 35 million people who are living with HIV. The number of cases in Armenia is still relatively small. It's estimated in 2013, I believe, at 1,730 cases. Now, HIV is highly treatable, but unlike tuberculosis, is not curable in most cases. There's a couple of exceptions in the United States where they've done some very expensive surgeries, that they've been able to actually cure people, but for the most part, it's not curable. There's nearly 10 million people on ARV drugs, antiretroviral drugs, which help to control the disease. Now, antiretroviral drugs, I'll show you some pictures later, have really been a miracle for controlling both the way that we treat HIV, but also controlling the spread of HIV, we discovered quite recently. But still, there are a lot of people who are eligible for ARVs worldwide who are not yet on them. For that reason, it remains the number 1 infectious disease killer. And these 2 epidemics are often called co-epidemics. They go together because we know that when you have HIV, your risk of getting tuberculosis, the active form, is 30 times greater. And so really, the HIV epidemic, as it spread, led to a resurgence of tuberculosis. So just to give a little bit of background in case you're not really familiar when I talk about these terms of active tuberculosis or latent tuberculosis. You can see here in many countries, people are exposed to tuberculosis for the first time as a child in most cases. And in virtually all of those cases, 79 to 90%, they don't develop an infection from it. 10 to 30% they do develop an infection, but in 90% of those cases, they develop latent tuberculosis after the active infection goes away, and they will never go on to develop active disease. But in 10% of cases, sometime in their lifetime, they will go on to develop active tuberculosis. Now, the interesting thing about HIV is instead of 10% over the course of one's lifetime, the risk is actually 10% each year if you have untreated HIV. So that significantly increases your risk of developing tuberculosis. If untreated, people often die within 2 years. But, in most cases, if you treat it, you can cure it. So first of all, I want to thank, this is from the National TB Director. These are slides that I've borrowed, I was given. So you can see here the trends over time in the number of new tuberculosis cases in Armenia. And Armenia has been making remarkable progress in controlling the tuberculosis epidemic, reducing the number of new cases, although there are still a fair number of cases, about 1,000 each year. Here you can see the number of TB/HIV co-infection cases, which has been increasing. There's been an increasing trend. And here we have the number of multi-drug resistant cases. So these are cases that are resistant to two of the major drugs used to treat tuberculosis. And MDR-TB, multi-drug resistant TB, comes when people begin a course of treatment and then they fail to complete that treatment. So it's often the case that people start feeling better after they begin treatment. A couple months into treatment they feel better, and then maybe they go back to work, maybe they go and migrate somewhere else, and they do not finish their treatment. And that's how we got MDR-TB. But now a lot of MDR-TB, there's a lot in Russia, and it's spreading, and we even have what's called XDR-TB, which is treatment-resistant tuberculosis, which is a very scary thing. But all in all, as I said, there's been a great deal of success, with the Stop TB program in Armenia, and you can see the number of TB deaths has been coming down. Does anybody know who this fellow was? This is always a... No, that's a good guess though. That would be the logical person that I would show, but that's not him. Anybody else want to guess this old man? So this is a picture of Louis Pasteur. And supposedly on his deathbed, this is what he said. And you can interpret it in different ways. I like to interpret it that on his deathbed, he regretted becoming a microbiologist because he wanted to go into public health secretly over his life. But I think this is a brilliant quote because it describes, with any epidemic, whether it's malnutrition, tuberculosis, whether it's tuberculosis or HIV or other things, you really have to understand the landscape because the landscape really is everything. And so what I would like to talk about is how nutritional status is a landscape within your body, which influences how disease progresses, but also how all of us are essentially contributing to a landscape which enables the spread of a disease or the lack of spread of a disease. So this is a classic sort of diagram illustrating the malnutrition infection. It's often called the vicious cycle or vicious circle of malnutrition and infection. And so in both tuberculosis and TB and in HIV, we all know that the classic sign of both of these diseases as they progress is wasting malnutrition, right? So this is a picture of somebody who has tuberculosis. Now, what contributes to that? Well, I mean, it's a little bit different in HIV versus TB, but there are a lot of similarities. And so if you just start at the very left side of the diagram, we know that in HIV people have, or in any active infection, pretty much people have increased nutritional needs. In both TB and HIV, people reduce their food intake. And there's issues with metabolism, absorption of food, and so that may lead to loss of nutrients as well. This in turn contributes to poor nutrition, resulting in weight loss, muscle wasting, and weakness. And in turn, that then cycles back and it impairs their immune system. And so he was talking earlier about vitamin D and cell-mediated immunity. And so we know that in particular with TB, vitamin D is crucial actually to controlling tuberculosis. So as a result of impaired immune system, then you get increased vulnerability to a lot of the opportunistic infections. And so somebody who has a impaired immune system cannot then fight off other infections or even the main infection, and that in turn leads to greater malnutrition. So I've talked about this a little bit, but there are basically three main ways through which, that we need to think about in terms of the way that HIV/AIDS affects nutrition and TB to some extent. So one is just reducing the amount of food that's consumed, right? And so the lack of appetite is very common in both diseases. Depression often contributes to lack of appetite. Mouth sores, but also because both of these diseases affect people usually in their wage-earning years, but especially HIV, they may have loss of income and loss of access to food, or perhaps stigma. They get, people stop talking to them, and so they cannot even rely on their family ties in order to be able to have that income that they once depended on. So that may also, food insecurity may also, and often does, is something that's associated with these diseases. There are also biological reasons, as I said, for greater loss of nutrients and reduced absorption. Diarrhea is very common. Infections of the intestinal tract. And also even when you go on to medication, some of these medications have adverse impacts on absorption of certain nutrients that you need to think about. And then with HIV in particular, it's documented that there's an increase in energy requirements, which I'll talk about in a little bit. But then there's also the other half of the cycle, which is the effect that malnutrition has and risk of infection. So this is very interesting. Now it's been thought for a long time that people observed that TB was an illness of poverty. So in the United States, just 100 years ago, the number one killer in Boston was tuberculosis. And at that time, tuberculosis had 3 different names, consumption and other things. So out of the top 10 causes of death, 3 of them were tuberculosis in different forms. So people have thought for a long time that people who were more thin or poorer are at greater risk of developing TB. And this is a graph that was from a meta-analysis that took 6 cohorts in different parts of the world, Finland, the United States, Norway, there may be one from Hong Kong as well. And what you see is body mass index on the bottom, and then tuberculosis incidence in the general population on the y-axis. And the y-axis is also, it's a log scale. And so if you plotted this in a normal scale, a line like that would actually go up like that as a curved line. And what you see is a remarkable log linear relationship. And this may be one of the few things that obesity, this graph here suggests that obesity may actually be protective against tuberculosis. But there's not a lot of data points above 30. So should you run out and get fat so you can prevent yourself from getting tuberculosis? Well, no, because there is a lot of evidence dating back to the 10th century even, 10th century, showing that diabetes and risk of tuberculosis are linked. And so this is also a meta-analysis of different studies, and you can see virtually every study that's looked at the relationship between tuberculosis and diabetes has shown that people with diabetes are at significantly greater risk of developing TB. You can see here for the cohort studies, the risk is about 3 times higher if you have diabetes of developing tuberculosis. And so a lot of people in the infectious disease world are now not only thinking about these 2 epidemics of tuberculosis and HIV, they're also thinking about this 3rd epidemic of diabetes. Diabetes may also, probably does affect treatment outcomes for people who are going on to treatment. There was a study in urban Indonesia of 737 people who were undergoing treatment for pulmonary tuberculosis. And in adjusted analysis, they found that those who had diabetes had a 7 times greater risk of I believe this was, not having, being sputum positive after treatment. So this is showing that the treatment was not successful. So this is really something to think about when you were thinking about the implications of diabetes. It's not just about direct risk of death, it's also about this. 5 minutes? Okay. So can nutritional interventions help to improve treatment outcomes? You've probably never seen, what it looks like. This is called the Lazarus effect. So this just shows you how remarkable these drugs are that we have. So this is just 2 months, I believe, after this woman got treatment for HIV. You can see the second picture there, and you can see how she is just a couple of years later. So this is really remarkable, the effect that having these drugs for HIV has had on people. The question is, do you need to complement the drug treatment with food or not? Well, we know that people who begin drug treatment with low BMI are at much greater risk of death. But that doesn't necessarily mean that, that they also require food, right? So here's what WHO says about energy requirements of people with HIV. So during the asymptomatic phase of HIV, before you get symptoms, there's about a 10% greater energy need. And then as people develop the symptomatic phase, there's an increase that rises to about 30% greater. But in this consultation, they found no reason to recommend an increase in protein or fat intake. And they also recommended just 1 RDA of essential micronutrients. Last year, for the first time, they issued guidelines on nutritional care and support. So if you have questions about what should be done or what's known about nutrition and tuberculosis, you can refer to these guidelines, which we can probably put in there in a folder for you. Yeah. But here are some of the key principles here, and really for a lot of tuberculosis, because so few studies have been done on nutrition and TB, a lot of the recommendations are just sort of drawing back to what we know for people without tuberculosis. So for the treatment of severe acute malnutrition, moderate acute malnutrition, a lot of those management issues, when you see malnutrition, you rely on the same guidelines that WHO has for people without TB. And the reason why is when they examined each of these different outcomes, they found very little evidence, quality of evidence for pretty much every outcome when it comes to supplementing with food or supplements was very low. Now, micronutrients deficiencies are very common among people with tuberculosis and HIV, but so far there just haven't been enough studies to really say much about it. I believe that vitamin D in the end will prove to be extremely important for treatment of tuberculosis, but the studies are just not there yet. So you can see the final conclusion. There's no evidence on the improvement of TB treatment outside of outcomes or prevention of progression to active disease when you're using nutritional supplementation. But one thing to think about, this doesn't necessarily mean that the programs that are going on right now providing a food basket should stop, because in thinking about this, they only thought about the clinical outcomes. They did not consider provision of food as part of a package of enablers to help people to complete TB treatment. And this is a really important point. For food insecure people, maybe it's worth investing whatever we can, especially for people with MDR-TB, to be able to complete their treatment. If food insecurity is an issue, maybe we need to think about whether or not it's worth that investment. It probably is. And it's certainly an issue. Here you can see treatment success rates of people overall in Armenia, and here you can see the treatment success rates of people with MDR-TB. It's much lower. And so actually I found out, just reviewing this presentation, that the social support program implemented by the Armenia Red Cross actually does provide social support and food package as part of the treatment. So there are guidelines out there if you're interested, and if you want to learn more about how to actually decide on what types of foods to give through these programs. I actually helped to write these guidelines. And I just want to say thank you to those who contributed slides and who I borrowed from here. And that's all. Thank you.
Thank you, Andrew. Very, very informative. Thanks. And our last formal talk of the conference is going to be given by Eugene Dinkovic, and we're going to be hearing about cow's milk, formula, and breast milk, the impact, or impacts, I guess, on infant and child development.
It works, you know. So if I'm going to be speaking too fast, you'll see the light going back and forth, and then I'll slow down. If, however, anybody in the audience thinks I'm speaking too fast, you can also wave your hand and I'll try to slow down. Yeah, it's fine. So I wanted to change the talk because I wanted to add a slide on diabetes and breast milk, since there was so much talk about diabetes today. Okay, so first of all, I want to thank again thank the organizers for the opportunity to speak here. This is a tremendous conference, and just going to once again to make a full circle, and after speaking about adult disease, HIV, tuberculosis, diabetes, to go back and bring everything back to the first year or 2, 3, depending, of life, and talk again about breastfeeding, I think is very important. In this country, you have been, I'm amazed at how well you are able to fix the problems when it comes to women breastfeeding and not breastfeeding, especially after the earthquake and after all that formula that came to the country. It's really amazing, and I think everybody here who was a part of it deserves tremendous credit. In fact, the breastfeeding rates here are certainly 2 or 3 times that I see in my hospital. So what I wanted to do is talk about and try to compare the cow milk, breast milk, and formula. And the reason is that twofold. Number one, a lot of people talk about breastfeeding promotion, but formula exists. And so it's important to kind of know the differences. Also, formula always cuts both ways. On the one hand, we don't like formula because we want breast milk, right? We want everybody to breastfeed. On the other hand, whenever I'm in a situation where baby cannot be breastfed, the mother is sick, the mother didn't make it, there's some other problem, then you hope for very, very, very good formula. So, right? And so what happens is you can only get good formula if there's market for formula. Otherwise, nobody would make it. So there's always things back and forth. So I think what's important is to understand the difference and know what's going on, what you're dealing with. So the first point is no matter how much the formula companies have been trying, they will never make formula like breast milk. Now, I'm only going to speak about cow milk-based formula. I'm not going to mention soy-based formula, soy bubble. There's a lot of problems with that formula, and I try very hard to avoid people using that. Okay, so as far as cow milk, and the formula comes from cow milk, the reason cow milk-based formula will never really be like breast milk is because of evolution and the way that humans and cows and their milk has evolved over the millennia for the specific needs of each of our species. In humans, it was walking on the rear legs, biped gait, and enlarging brain size that determine the composition of human milk. So when humans walked upright about 2 million years ago, what happened? Two things happened. On the one hand, the brain started to increase because now we could use our hands, right, to do things, and the communication between humans. So for that, we need a bigger brain. On the other hand, the pelvis got smaller. And the reason the pelvis got smaller is because of the issues of center of gravity, right? The pelvis became, especially in women, wider from side to side and narrow from front to back. So this is what this looks like, right? So here's your typical cow pelvis, right? Nice, round, big hole, right? You can get a very big, calf, hedonic, right through here, right? On the other hand, here's the human pelvis, right? Wide from side to side, narrow from front to back. It's a problem. How do you get a bigger enlarging brain, so a bigger enlarging head, through a smaller hole, right? So evolutionary solution was to deliver the fetus at decreased levels of maturity. Now, the moment you do that, what happens? That immature newborn is at much higher risk of death, right, due to the fact that the fetus is immature. So humans have adapted their breast milk to make up for the immaturity of the newborn by secreting bioactive components, right? These components lack in cow milk because there's no pressure on the cow to do that. Now, if the cow starts to walk on rear legs, in a few million years, cow milk will be very, very good. But until then, it's not going to happen. Now, I have a duck-billed platypus here, right? This animal comes from Australia, right? And the reason I have her up here is because this is an animal that lays eggs, but after the legs hatch, it nurses its young. And so the point is that the mammary gland evolved before the placenta, and it just shows how important the mammary gland is. Okay, so what we're going to do next is we're going to talk a little bit about the nutritional differences and the different immune modulating factors in breast milk, cow milk, and formula. I only have a few minutes, so this is going to be a very, very short review. And now there's over 200 different bioactive components in breast milk. And that's what we know so far. There's actually probably a lot more. And each one of them probably has more than one function. So again, I can't cover that in days and days, so we'll just talk about the major things. All right, so first thing, let's just talk about again review the fact that breastfed infants and formula-fed infants grow different, right? So here, what you see is growth of a breastfed infant, and this is the percent body fat, and here's the age in months, right? So this is breastfed infant, and the upper curve is for the formula-fed infants. So you can see that formula-fed infants have significantly more body fat, right, by 3 months of age, but they kind of come close together when they get to be 2 years old. But there's an idea that maybe they diverge again, so the formula-fed babies have more body fat later on and become heavier adults. Right, now why is that possible? Well, how does that happen? Well, there's a number of different possibilities. There are possible problems with growth factors in breast milk, or a fact that cow milk has no growth factors, different endocrine responses to feeding, differential control of food take, and we'll talk about how breastfed babies learn how to self-regulate, whereas formula-fed babies might not. And there's differences in nutrient components of food. Basically, the formula typically is always the same. So in this country, I presume that you give the same formula to a newborn that you would give to a 10-month-old, right? In the United States, that's changing. It's becoming cost-effective for formula companies to make special formula for the first 3 months of life, for the next few months of life, and even they start to make formula for the second year of life. But that's because they're trying to make money. All right, so now, there's also differences in energy, right, and energy intake, which may be responsible for difference in percent body fat. Right now, there's equal energy density in breast milk and formula, about 670 kilocalories per liter. But if you look at how much energy babies, formula-fed babies and breastfed babies consume, there's a difference, right? So if you look again here that the solid line, the black line, is for formula-fed babies, and pretty much at every month, right, formula-fed babies get more energy. Why is that? The one problem is that when researchers in the 50s decided to figure out how much energy is there in breast milk, they took the breast milk and burned it and see what they got, right? But we know that many components of breast milk are not used for energy, right, but used for other things. For instance, modulating the immune system, as we're going to talk in a minute. And so actual amount of energy is less probably in breast milk than in formula. Now, secondly, breastfed infants take less volume than formula-fed infants, right? So about 200 milliliters per day difference at 3 months of age, right? And that may be because they can better regulate their intake. So the bottom line is energy requirements of infants might have overestimated the true energy requirements by 10 to 30%. Okay, now we're going to talk about the major nutritive components of cow milk, breast milk, and formula, and talk about the major differences. So let's talk about fats or lipids first, right? The colostrum is very low on fat. Early milk has 3.5 to 4% fat, and mature milk has a little bit more. Now, fat is very important because breastfed babies grow on fat, right? So we have to make sure that they get adequate amount of fat. Formula has about 3.5%, but there's significant differences in the type of fat that's present in cow milk and breast milk. Particularly, cow milk lacks long-chain polyunsaturated fatty acids, known as arachidonic acid right here, and DHA, docosahexaenoic acid, right? And so that's because the calf, who's mature, can just make them right away. For us human babies, is essential. We cannot synthesize it. So about 15 years ago, they started to add those long-chain fatty acids to formula, and that's added in Armenia as it is added other places around the world. Okay. Now, there's also differences, and this is very important because it becomes important clinically, in how lipid works, right? So we know that we cannot put fat into a polar solution, so actually lipid exists in breast milk in a milk gut, right? So you have the polar component on the outside and the fatty acids on the inside. And they sit on a triacylglycerol backbone. So now, the interesting thing is that fatty acids are arranged in a specific order that allow easy digestion by lipases, right? And remember that each enzyme only breaks one bond. So what happens is that these lipases can come in one at a time, break the bond, and digest the milk globule in breast milk, right? So that's why baby who is being breastfed, usually especially early on, a couple of days, a week of age, the stomach is emptied of milk in about 2 hours. So the baby wants to eat all the time, every hour and a half, every 2 hours, right? Baby's hungry nonstop. On the other hand, when you make formula, you have to heat the cow milk because you have to pasteurize it. When you heat the cow milk, you break, actually, and destroy this nice architecture here. So now there's more energy that's required to digest the fatty acids off of the triacylglycerol, and also it takes longer. So what you would see is a baby getting formula, the baby will fall asleep, right? And the baby will sleep for 3-4 hours until the stomach is empty. The formula takes about 4 hours, right? And the mother will say what? The mother will say, hey, my baby's good, now he's sleeping, he's not waking up every hour and a half, right? And this has very important clinical implications because in an environment where I work, where formula is ubiquitous, everybody has formula, right? And so what the mother would do is she would say, okay, I'm giving my baby breast milk every hour and a half, he's hungry nonstop. Obviously there's something wrong with my breast milk. Then she says, okay, my grandmother or my friend, somebody's telling me to try formula. I'm going to try formula. And what's going to happen? The baby's going to fall asleep and sleep for 3-4 hours. The mother's going to get a break. She's going to say, wow, something wrong with my breast milk. What is she going to do next? She's going to look at her breast milk, right? And what is she going to see? She's going to see very, very thin, watery liquid, right? And then she's going to look at formula. And what is she going to see in the formula? It's nice, thick, and creamy. It looks like milk. By the way, That's a marketing strategy. The oils that they use to make formula, it's done so that it looks thick and creamy. And then she's going to say, okay, I'm not going to use my breast milk. Obviously, there's something wrong with it. All right, so this has important implications. That means that we have to explain to parents that what is normal and what is not normal. And being hungry every hour and a half, unfortunately, for the mother, for the first few weeks of life, is normal. Okay, so we're going to switch, talk about lactose, right? And now, the predominant carbohydrate in both cow milk and human milk is lactose, right? But there's more lactose in human milk than in cow milk. In cow milk. And remember that structure of lactose is glucose and galactose. And it's a major energy source for the brain. So whereas baby gains weight on lipid, the brain gains weight on lactose, right? And now lactose is also important because it's used to make galactolipids, and particularly some phosphoripicides, which are needed for central nervous system development. So you want to use lactose-based formulas as much as possible. Okay, next thing, we'll talk about protein. Right? Now, there's a lot to be said about protein, so I try to make this simple, but I'm not sure you'll have to tell me if I succeeded. So, first of all, in different types of milk, there's different amount of protein. Right? So colostrum has lots and lots and lots of protein. Right? 20 to 30 grams per liter. In fact, it has more protein than formula, which has about 12 to 14, more protein than early breast milk, and more protein than late breast milk. Anybody want to guess why there's so much protein in colostrum? Anybody? Okay. The reason, I'm sorry. I'm trying to get people. Yes, so I'm sorry. Colostrum is the very first milk. It's that brownish stuff, right, that you see, you can squeeze a little bit out of the breast for the first. Есть? Окей. Все поняли, да? Окей. Я, кстати, не знаю, как сказать колостrum по-русски. Алозе, спасибо. Okay. Okay. So anyway, the point is that the reason there's so much protein in colostrum is because a lot of that protein goes to do the very first thing that that fetus or that now newborn has to do to survive, and that is to mature the gut. Right? The gut is very, very permeable to everything. Right? So bacteria, viruses, anything can get between the cells right inside the baby and cause allergies, cause infection. So the first thing that has to happen is the gut has to be matured. So a lot of the protein is not protein used for nutrition. It's different growth factors and other things that's used to mature the gut. Right? Okay, so then you have early breast milk and late breast milk. So as you can see, there's more protein in formula because it's easy to digest, and so there's no problem for the calf. Right? You can crack that protein down right away. Now, there's also different when it comes to nutritional proteins. We have whey and we have casein. Right? It's a very easy experiment to do to see which one is which. I'm sure everybody's done it. You take a little bit of milk, you put a little bit of lemon in it, right? And what happens? The little curds is the casein, the liquid is the whey. So what happens? We use acid actually to digest things, right? So casein is difficult to digest, whereas whey is very easy to digest. So not surprisingly, therefore, in early breast milk, most of the nutritional protein is whey. There's a lot of whey and very little casein. Right? At 6 months of age, what you see is the amount of casein increases and the amount of whey decreases. That's because casein is needed for some reason more, right? It's a better nutritional protein. And by 6 months of age, the baby is able to digest it much better. On the other hand, cow milk is mostly casein, 80%, very little whey, right? So now, what happens if you give newborn cow milk that the newborn cannot digest the casein, and so casein sits in the stomach and prevents actually formula or breast milk to flow out of the stomach because it blocks the outlet of the stomach. So we never give cow milk to newborns, obviously. There's also difference in the types of amino acids, right? Cow milk has more sulfur-containing amino acids, and cow milk does not have taurine. Now, taurine is also very important for development, so it's been added to formula. Now, the other point I want to make, and this is also pretty important, is that formula-fed babies not just only get more energy, they also get a lot more protein. So if you look here, formula-fed babies get significantly more protein at any age than breastfed babies. Now that's important because this is thought to be one of the reasons that babies who are getting formula are thought to be more likely to become obese and overweight than breastfed babies. The way it works is that, again, formula-fed infants get about 70% more protein than breastfed infants in the first year of life. This excess protein causes particularly insulin-releasing amino acids, programs for babies to have higher insulin resistance and therefore to become heavier. Right? So Dr. Koletsko here, I have as a reference, I think this is a very interesting study, decided to study, could this be true? So what he did is he took different formulas from Europe. Some have more protein, some have less protein. He randomized kids to get one or the other, and then he had another set of kids who were getting breast milk. Obviously, he couldn't randomize kids to not get breast milk. And what he did is he looked over time what happened. What he found is that kids who were getting higher protein formulas, in fact, were significantly heavier weight for length, and at 1 year of age and 2 years of age, and also for BMI at 1 year of age and 2 years of age. Whereas those babies who were getting lower protein formulas grew, were smaller, or thinner, I should say, and also were growing just like the breastfed babies. So what that means is probably the amount of protein in the formula may need to be adjusted, and we might still see that a few years from now. Okay, now the next thing we're going to do is, this is all I'm going to say, and this is really very, very little about the nutritional components of breast milk, just because there's not much time. And so now what we're going to do is instead of looking at biochemistry, we're going to look at the big picture. And the one thing I want to talk about is whether or not obesity is associated with getting formula, and does breast milk and getting breast milk instead of formula protect from obesity. Obviously, it's a big problem for us in the United States. So what I have here is a meta-analysis plot. I'm going to show you a bunch of these. So I want to make sure I explain how this works. So this is basically this vertical line. So over here, we have all the different studies, okay, on the left. Okay, so every one of these lines is a different study. So we have about 29 different studies. On the vertical line here is odds ratio of 1. So anything that is to the left suggests that breast milk is protected from obesity. So any of the studies that have the long line here, the confidence interval on the left, says that breast milk is protected from obesity because it decreases the odds. And anything that's on the right says that or crosses this vertical line says that this is not so. So again, what you can see here is that most of the studies are on the left, which means that, and these are prospective cohort studies. These are not randomized control studies because, again, you can't randomize children to be formula fed, right? And when you put all these studies up together into one super study, what you get is the result over here. And basically, the odds ratio is decreased by 13%, meaning that if you breastfeed your child as opposed to formula feed your child, you're decreasing your risk of the child being obese at 5, 10, 15 years of age by 13%. Now that's great, right? Especially in Armenia where you have a lot of breastfeeding, right? But there's formula. Now that you're having more and more, we saw Kentucky Fried Chicken yesterday. It was rather disappointing, right? But that probably means that there's going to be more and more obesity because that's what Kentucky Fried Chicken brings, right? So it's important to be able to protect the kids. So now, if you can decrease the rate of obesity by 13%, that's great. That's great for the population. It's also great for individual patients. However, the problem is that there's a lot of confounding. Okay? So now, what do I mean? So for instance, if somebody has lower socioeconomic status, and this study comes from the United States, those women are less likely to breastfeed, but more likely to have obese babies. Same thing, if the mother is heavy, she's more likely to have an obese child, but less likely to breastfeed. And the same thing goes for smoking. Women who smoke are less likely to breastfeed, but a lot more likely, fourfold actually, more likely to have an obese child. So when you control for these, and out of these 29 studies, 6 controlled for that, the benefit of breastfeeding as far as reducing obesity was reduced down to 7%. So what does that mean? You know, is that good or bad? See, I'm an optimist. I think this is, at least in this place, I think this is good. So even when you control for something, right, you still see a benefit, number one. And number two, 7% decrease in risk is a very, very significant benefit for a population. Might not be great big benefit for an individual child, but for a population of Armenians, I think it would be very, very important. Okay, so now we're going to talk about something that I'm very, very curious about, and I think is very, very important, and that's about breastfeeding and short-term and long-term benefits to the offspring, right? Because we have spent a day and a half here talking about life cycle, right? And that things that you do to a baby, even, you know, the grandmother effect, right? The grandmother effect. What happens to a woman when she's forming her eggs, right, is going to affect her grandchildren, right? So does that work for breast milk as well? So we're going to talk about that, right? So in fact, it does, right? Because breast milk is very, very important in its relationship to maturing the immune system. So here's how I understand this to work, right? So in my opinion, the immune system is very, very complicated. This, you know, what I learned about the immune system 25 years ago, everything's completely changed. But somebody taught me that my immune system is just like a guard dog. How do you say guard dog in Armenian? Perfect. Okay. Yes? So, okay. So why? Because what do you want your guard dog to do? You want your guard dog to recognize you, right? So it doesn't bite you. Yes? Same thing with the immune system. You want it to recognize you so you don't get autoimmune disease. Yes? You want your guard dog to recognize your friend, right? So it doesn't bite your friend when you bring him to your house, right? So the same thing here, right? The immune system, you want to have tolerance, meaning it's not going to go after, after things that you shouldn't go after, right? So for instance, pollen, right? You don't want to have allergies, right? And finally, if a thief is trying to get in, you want your guard dog to bite the thief, right? So how do you do that? You have to make sure that you train your guard dog well. And so if you train your guard dog, what do you get? You get this, yes? Right? And what happens if you don't train your guard dog well? You get this. Right? Okay, so immune system works the same way. So you have to train your immune system. Your immune system in the fetus, and as soon as the baby comes out, is very, very much ready to bite everything. Okay? So it will go after any allergen. It will go, and there's a lot of biochemical stuff that I'm not talking about. I'm making this very basic because this is how I understand. Okay, so you want to train the immune system. So what trains the immune system? Breast milk does. How does it do it? All right, in many different ways. But what happens is during vaginal birth, newborn's GI tract, right, is contaminated, right, by maternal GI flora, essentially feces. Right? Now, these feces are very, very important because in them we have very, very important bacteria, Bifidobacterium and lactobacillus. Right? These bacteria actually interact with the immune system and train the immune system not to attack itself. So for instance, you don't get autoimmune disease as much as I'll show you. Right? It also trains the immune system not to attack allergens such as pollen. Right? Now, what does breast milk do? Breast milk does a lot of different things. One thing that does, in it has oligosaccharides. These oligosaccharides function as substrate for this bacteria. And so what happens, the bacteria eats the oligosaccharides and releases chemicals that actually decrease the pH. Right? But this bacteria likes to live in low pH, but pathogenic bacteria, right, likes to live in high pH. Yes, I'm going to slow down now. Okay, likes to live in high pH. So therefore breast milk actually promotes better development of the immune system. So therefore, okay, so now how does that work in real life? So what I'm going to do next is just talk about what you see clinically with babies who are breastfed versus who are formula fed. So this first slide is something that you probably know very well and very familiar with, but I have to remind doctors about this all the time in the United States. Breastfeeding protects from sepsis and it protects from diarrhea. Now this is an interesting study. It wasn't really a study. They documented what they did in the Philippines. In the Philippines in the 70s, right, during period 1, which is over here, they did a couple of things. Number one, they were not promoting breastfeeding. So therefore only half of the mothers would exclusively breastfeed. and also they kept babies from getting to the breast for about a day. Okay, and so look how much sepsis there was during the time period, here and here. Right, then they discovered religion, if you find the expression, they decided, okay, breast milk is it, and so during the second period, right, they were now increased the breastfeeding to 85%, and they allowed the mothers to feed as soon as possible. It wasn't like now, 1 hour, but it was the same day. And you could see that the amount of sepsis and diarrhea decreased significantly, right? You couldn't do this study today, it would be totally unethical, but it's interesting. Okay, so now, the breastfeeding protects from a bunch of other things. Not surprisingly, if we said that we're going to train our guard dog right, breastfeeding protects from asthma, because asthma is an allergic disease. So in fact, again, these are the same thoughts. If the results are on the left side, that means that breastfeeding protects from asthma. If the study is on the right side, it means that they actually make the asthma worse. So majority of the studies over here, and if you look, this is the summary result. So what that means is, if overall, breastfeeding cuts down rate of asthma and allergy by 30%. If either mother or father have allergies, it cuts the risk of allergy in an offspring in half. Right? So it's very, very significant. So that's one reason to breastfeed. 5 minutes, I'll be done. Okay. Now, I had to put this slide in because we were talking about type 2 diabetes. And again, the same plot, and as you can see, that odds ratio of type 2 diabetes in a breastfed baby, obviously when that baby grows up, compared to formula-fed baby, is significantly less. Here it is, right? So in fact, decreased by about 40%. So if we want to protect our future children from diabetes, right, then we have to promote breastfeeding. Now, there's also some evidence that lactation, so breastfeeding, also protects the mother from developing diabetes. That's even more interesting, right, because this is 2 for the price of 1. It also protects, breastfeeding also has been shown to protect the mother from getting breast cancer. Breast cancer is a very big problem in the United States. 1 in 8 women in the United States get breast cancer. So the more children you have and the longer you breastfeed each one of them, the less likely are you to get breast cancer. And if a woman, or if a young woman, 16, 17, 18 years of age, gets pregnant and then breastfeeds her baby for a year, her likelihood of getting breast cancer is very, very low. Now, we don't advocate 17-year-olds having babies, but nevertheless. Adults from having autoimmune disease, not just when they're children. And finally, I want to talk about something that's still considered to be controversial, and that's the relationship between breastfeeding and cognitive development. There's more and more studies coming out showing that breastfeeding increases IQ, right, and does other things. So here's 4 studies. So for example, head circumference was found to be larger, so the brain is larger in babies who were breastfed compared to those babies who were formula fed, right? Development of the brain white matter was better in babies who were breastfed compared to formula fed. IQ, right? Now, there's a guy named Kramer, a gentleman named Kramer, who did a study in Belarus where he randomized mothers. He couldn't randomize them to not breastfeed, but he took half of the mothers and really helped them to breastfeed for a long time. So he looked at the effect of duration of breastfeeding. So the mothers who were in the experimental group were breastfeeding for maybe 6, 7, 8 months, I don't remember exactly. The mothers who were formula feeding breastfed for significantly less time. What he found is that artificial feeding, so formula feeding, decreased IQ by almost 6 points, right? When these children were 6.5 years of age, right? And since this was a randomized controlled trial, you kind of get the socioeconomic issues and mother's own IQ issues out of it, right? So this can be believed, right? Sounds now like possibly be true. School achievement has been shown to be better with breastfeeding, and moving up social classes in England. And England, from what I understand, is a very rigid society of social classes. You're moving up, you've really moved up. So it was also shown to be better if you were breastfed. So that's about it. In summary, so we call this something in America, breastfeeding is the gift that keeps on giving. I don't know if there's an expression like that in Armenia. So you do it once and it's good for your whole life, right? So I'm hoping that when I'm 95, I'm still going to get the benefit of the fact that I was breastfed. And I wish that to everybody here. Yeah, an optimist, right? Yes. But particularly breastfeeding is important because for prevention of infectious disease and related growth failure, at least early on, right? Prevention of obesity-related adult disease, whose prevalence is increasing here in Armenia, and I believe, because I saw that Kentucky Fried Chicken, it's going to get worse and worse, unfortunately, right? And can it possibly be a compensation for cognitive development that's conferred by stunting, right? Could it be somewhat protected from that? So the bottom line is, I think all of you get great credit for doing everything that you're doing to promote breastfeeding, and those, all those efforts have to keep on be continued. Thank you very much.
Well, thank you, Eugene. And because of time limitations, we're going to save some of the discussions for the next conference. Well, we've had quite an interesting day and a half. Who feels they've learned some new things? Okay. Well, I've learned a tremendous amount too. And not only did we learn that the double burden exists in Armenia, but in some ways it's a lot worse than in the neighborhood, Europe compared to North America. So the first step in handling a problem is to recognize that there's a problem. And I think we've come a long way towards recognition. Certainly on the undernutrition side, we've learned that we've got to make some headway here in understanding the root causes. We've learned that Armenia has stunting, and even if the measurements are off by 3-4%, it's still much farther ahead than the neighborhood, in many parts of the neighborhood. And we've learned it's a different kind of stunting. We've learned that it's sort of late onset. Babies aren't born that way, they're getting that way, and happening after 6 months of age. We've learned that anemia is a big problem, and we suspect that there are major micronutrient deficiencies. Interestingly, from the data we heard yesterday on Tarush, intestinal parasites could be a contributor, and they're easily treatable. We have to look for other things. There's been a bit of talk on the sides as to could toxicities from lead or arsenic be important in some areas of the country. On the overnutrition side, I must admit, I was frightened. Frightening statistics in terms of myocardial infarction, stroke, diabetes, cancer, probable bone disease, and calcium deficiencies. We've heard about clinical conditions where nutrition can have a key role. And then we can also have an appreciation that there are some tools that we can use towards approaching the double burden. We've learned about nutrition-sensitive and nutrition-specific assessments and interventions. We've heard of the importance of utilizing growth curves. These are just some examples. And we've learned that Armenia can really have an Armenian plate. And we've seen how that plate, for example, in Tallinn, in terms of diversity, may be an approach towards stunting control, one of the approaches. We have good tools in Armenia, such as anthropometrics, but still there's some gaps. It seems to me that hemoglobin is mainly measured by just as hemoglobin without necessarily having complete blood count indices. Although the Hematological Institute can measure ferritin and folic acid and probably some other micronutrients, it's not widely available. And I'm not sure about the ability to measure lead and arsenic, other toxins in Armenia. I think some of it, no, very limited. So we have to figure out now what should be the approaches to solving these problems. How do we solve them? Well, first of all, as I said, recognize them. We have another important solution. We just heard about it, a terrific survey of the effects of breastfeeding, which is working, but still can be better in Armenia as a life cycle approach. And we've heard from what's happening, for example, 2 examples in Tallinn and Kabush of intersectoral approaches. It can't be just one, depending on vitamins or single approach. We've discussed how nutrition, education, and training has to be part of the solution. The community level, individual level, the health professional levels, and interprofessional levels. It's got to be improved here. It's got to be improved in North America as well. We need to improve clinical nutrition for patients in the hospitals, and we also need to increase our research skills, our monitoring and evaluation skills. And I think that in the title of my closing here, something says, the cost of doing nothing. Well, in fact, what I've learned in the last 2 days is that some things are being done, but it's not enough. And here, in terms of the title of the conference, nutrition as a key to economic development. Notice it says a key. It's not the key. It's a partner in the economic development, and I think that's what we have to advocate for. So as we move forward, I think we can say that this conference has really been helpful in setting the stage for increasing the realization of the need for Armenia at the government level, political level, as well as the levels of the people that are represented in this room, to really invest in nutrition and lifestyles. On behalf of everyone, I'd like to thank the organizing committee from FAR, World Vision, American University of Armenia, the AUA students who have made this meeting run so well. And the co-sponsors, the Janishian Foundation, AAHPO, the Armenian Medical Fund, and the JNF Foundation. And really, special thanks to you participants for allowing us from Columbia University to take part in a conference that we all believe now will make a difference for Armenia. Thank you very much. Any last words? So, we can officially call the conference to a close with the good news that the Armenian plate is waiting.